Hi, I am a class 4 antiarrhythmic drug. My generic name is verapamil. In the Philippines, I am available as isoptenas are Rightmid, verapamil, and Verol. In the USA, my common known brands are Callan SR, Cuvera HS, and Verilan. This is my chemical name. I am therapeutically classified as an antiarrhythmic drug. I fall into pregnancy category C. There are no well-controlled studies that have been done in pregnant women. I should be used during pregnancy only if the possible benefit outweighs the possible risk to the unborn baby. My mechanism of action. I bind to L-type calcium channels located on the vascular smooth muscle, cardiac myocytes, and cardiac nodal tissue. These channels are responsible for regulating the influx of calcium into muscle cells, which in turn stimulates smooth muscle contraction and cardiac myocyte contraction. In cardiac nodal tissue, L-type calcium channels play an important role in pacemaker currents and in phase zero of the action potentials. Therefore, by blocking calcium entry into the cell, I cause vascular smooth relaxation or vasodilation, decreased myocardial force generation or negative inotrophy, decreased heart rate or negative gonotrophy, and decreased conduction velocity within the heart, particularly at the atrioventricular node. I think that was a lot of information. Let us try again, but with easy words. I cause suppression of cardiac and smooth muscle contraction, decreased automaticity, and decreased conduction velocity, so I lead to less stress in heart. I work as a calcium antagonist. Calcium causes the heart and arteries to contract more strongly, so by blocking calcium, I allow blood vessels to relax and open, and thus I lower blood pressure. If I am taken orally, my onset is within 1 to 2 hours with a duration of 6 to 8 hours. If I am taken intravenously, my onset is within 5 minutes with a duration of 10 to 20 minutes. Orally, I am approximately 90% absorbed from the GI tract. My bioavailability is 20 to 35%, and my time to peak plasma concentration is 1 to 2 hours. My distribution is that I cross the placenta and enters the breast milk. My metabolism is a volume of distribution is 3.89 liters per kilogram with a plasma protein binding of approximately 90%. I am extensively metabolized hepatically to at least 12 metabolites. An example is verapamil as primary metabolites. My excretion is via urine, 70% as metabolites, 3 to 4% as unchanged drug, and feces is 16%. My terminal half-life is 2 to 8 hours, increases to 4.5 to 12 hours after oral repeated dose. My intended use is to treat hypertension, to treat and prevent chest pain or angina, supraventricular arrhythmia, and atrial fibrillation, chronic atrial fibrillation, and paroxysmal supraventricular tachycardia, supraventricular tachycardia in pediatric, and tardive dyskinesia. I am contraindicated to patients with hypersensitivity to verapamil or any component contained in the verapamil formulation, immediate release of extended release, severe dysfunction of the left ventricle, severe hypotension defined as a systolic blood pressure reading of less than 90 mm per mercury or cardiogenic shock, except in patients with a functioning artificial ventricular pacemaker. 6. Sinus syndrome and second or third degree atrioventricular block, the main exception being in patients who have a functioning artificial ventricular pacemaker. Atrial flutter fibrillation with an accessory bypass tract. Severe heart failure, unless the heart failure is a result of a supraventricular tachycardia responsive to verapamil. Concomitant use of intravenous beta blockers. I have possible side and adverse effects in the body systems. In the central nervous system, weakness, dizziness, fatigue, depression, and headache. In the endocrine system, nausea, vomiting, and GI distress. In the cardiovascular system, hypotension, shock, edema, and arrhythmia.
Hello, I am your nurse for today, and here are my nursing considerations. Before initiating drug treatment, I need to conduct a comprehensive physical test to assess baseline status, determine therapy efficacy, and evaluate possible adverse effects. Assess the neurological state of the patient to recognize possible central nervous system drug effects. Carefully assess cardiac status such as blood pressure, heart rate and rhythm, heart sounds, among others, to decide if drug dosage adjustments are imperative. Track laboratory tests including full blood count, renal and liver function tests to assess the need for possible change in dosage and detect toxic effects. Nursing considerations during administration of drug. During the patient's regimen, in order to minimize the chance of drug overdose, I need to titrate the dosage to the smallest level necessary to handle arrhythmia. To identify potentially serious adverse effects and to assess medication efficacy, I need to track heart activity closely. I also need to provide comfort and safety measures to help patients tolerate drug reactions such as side rail elevation, sufficient room lighting, and noise control. I also need to ensure which emergency medications and bedside equipment are preserved to facilitate timely care in cases of serious toxicity. In order to increase patients' awareness of drug therapy and thereby facilitate adherence to the drug regimen, I need to inform patients on drug therapy, including drug name, its indication, and adverse effects to look out for. Nursing consideration after administering the drug. After administering the drug, I need to track the response of the patient to therapy by measuring cardiac production and rhythm. I also need to monitor adverse reactions such as sedation, respiratory disturbance, and symptoms relating to the central nervous system. I also need to test patient awareness of drug therapy by asking the patient to name the medication, its indication, and adverse effects. And lastly, I need to track the commitment of the patients to drug treatment. Until next time, it was Jolina Cabataña as the class for antiarrhythmic drug and John Casas as the nurse.